Hello friends, let us now learn some important points about the chronic wounds. Chronic wounds are those wounds which do not heal within 3 months of time, then we call it as chronic wounds. The delay in healing can be due to the prolonged inflammatory stage. So we will see the classification of the uh, chronic wounds. First type of chronic wound is we have deglowing wound or deglowing injury. Here there is avulsion of skin and subcutaneous tissue from the underlying fascia. There is avulsion of skin and subcutaneous tissue from the underlying fascia. So as a result, you will see present exposure of neuromuscular structures, tendon and bone are exposed in this deglowing injury. Then we have the second type, which is called as compartment syndrome. In this compartment syndrome mainly occurs in the lower limb injury. Compartment syndrome mainly occurs in the closed lower limb injuries. Okay, and if you see, this compartment syndrome is associated with severe pain, and you will also see presence of pain on passive movement. Pain on passive movement is seen in this compartment syndrome, and at the end there will be, because this occurs due to increased compartmental pressure. Okay, this compartment syndrome mainly occurs due to the increased compartmental pressure. When this compartmental pressure increases such that at some stage this can compress the arterioles, finally resulting in absence of distal pulse, and this is the late sign which is seen. Then how do you diagnose? Diagnosis is that you will have to measure this compartmental pressure. This is actually measured by the pressure monitor or the catheter which is placed in the muscle compartment. So with that we will measure the compartmental pressure, and if you see that the compartmental pressure is more than 30 millimeters of Hg, then you will have to do fasciotomy. Okay, so if the compartmental pressure is more than 30 millimeters of Hg, you will have to do fasciotomy. In fasciotomy, you will give the incision through the skin, subcutaneous tissue and fascia, and you will release the tension present in the muscles. Okay, so that is about the fasciotomy and compartmental syndrome. Then we have the third type of chronic wound is pressure wound. This pressure wound is given many names. This is also called as bed sore or pressure ulcer or decubitus ulcer or tropical ulcer, or we can trophic ulcer, or we can also call it as penetrating ulcer, right? So this will actually cause tissue necrosis. And ulceration, mainly because of the prolonged application of pressure. It causes tissue necrosis and ulceration. So if you see the mechanism, first there will be external pressure, and this external pressure, this will be when the external pressure is more than the capillary occlusive pressure, that is the pressure required for closing the capillaries, which is around 30 millimeters of Hg. When the external pressure is more than this capillary occlusive pressure, now the capillaries will get blocked. As a result, there is decreased blood flow to the skin. So this will result in necrosis, tissue hypoxia, necrosis and ulceration occurs. Right? Now, the other mechanisms can be, because of this decreased blood flow, there can be decreased nutrition, and there can be neurological deficit is also seen. Okay, this is a preventable cause, and it is seen in almost 5% of hospitalized patients. Here this has increased incidence especially in paraplegic patients because they cannot walk and there is increased pressure at one certain area of our body that is dependent for. It is seen in elderly and in severely ill patients. You will see that there is higher incidence of this pressure source. So the most common site of pressure source is ischium, followed by greater trochanter, followed by sacrum, followed by heel, followed by greater malleolus, that is lateral malleolus more than medial malleolus, followed by occiput. So the best is ischium. The most common site is ischium, followed by greater trochanter, then sacrum, heel, malleus and occiput. Okay. Now if we see the neurological causes which will result in this pressure sore, the etiology of pressure sore, if you see, this can occur due to some neurological causes like syringomyelia, spina bifida or spinal cord injury, and peripheral neuritis, peripheral nerve injury or diabetic neuropathy or paraplegia, leprosy and tabes dorsalis. In all these cases you will see that there is increased risk of pressure sore. So in the beginning, if you see the clinical features, you will see first there will be painless punched out ulcer is seen with the base formed by the bone. So this is called as the pressure sore. Then first we will have to see the stages of pressure sore. Pressure sore is divided into 4 stages. Stage 1, where you will just see the erythema. So this is mainly non-blanchable erythema. So this non-blanchable erythema will progress to early superficial ulcer. It progresses to early superficial ulcer. Then we have second stage, where you will see presence of late superficial ulcer is seen in stage 2. Okay. Then we have stage 3, where you will see presence of early deep ulcer is seen in stage 3, and in stage 4 you will see the presence of late deep ulcer. So if you see the stages of pressure sore, there are 4 types. One, stage 1, which is non-blanchable erythema, that is early superficial ulcer. Stage 2, late superficial ulcer. Stage 3, early deep ulcer. Stage 4, late deep ulcer. Now if you see the treatment, first, prevention is best treatment in pressure sores. So we will have to give good skin care to the patient, and we can give special pressure depression cushions of foam can be used. Pressure dispersion cushions of foam can be used. So these will decrease the pressure, outside pressure, and gives good flow of blood. And we can also use of low air loss or air fluidized bloods will be present, which can be used. Right. Then one important thing is, if any patient is bedridden patient or bedbound patient, we will have to turn the patient at least every 2 hourly. Every 2 hourly we should turn the patient if the patient is bedridden. Then if the patient is wheelchair bound, then we will have to wheelchair bound patient, we will have to lift them off their seats at least every 10 seconds for every 10 minutes. Every 10 minutes we should lift them for 10 seconds if the patient is wheelchair bound. If the patient is bedridden, then we should turn them at least every 2 hourly. Then surgical treatment is only reserved if there is no improvement in conservative treatment. So first we will do conservative treatment, where we can give adequate debridement can be done, followed by vacuum assisted closure and flap closure can be done. This is the surgical treatment. In the surgical treatment we do early debridement, vacuum assisted closure and flap closure is done. This is done only if the conservative treatment is not sufficient or does not heal the wound. So first we have to see vacuum assisted closure, or we can also call it as negative pressure wound therapy. So in this vacuum assisted closure or negative pressure wound therapy, we will have to see that here this negative pressure wound therapy is minus 125 millimeters of Hg. This will, you will give this negative pressure is put over the wound, and this will promote the wound healing by applying vacuum. It will promote the wound healing by vacuum application, right? Continued vacuum will draw out fluid from the wound and increases the blood supply or blood flow to the area. So if you see this, the primary effects of this negative pressure wound therapy or vacuum assisted closure, if you see the primary effect, it causes macro deformation. That is, it will cause the wound edges to come closer to each other. Second, it stabilizes the wound environment. That means it will protect the wound from any microorganisms from outside. Then it will provide the warmth to the wound and moist environment to the wound. This will decrease the edema, thus removing the soft tissue exudate, and it will also cause micro deformation. In micro deformation, there is cellular proliferation of wound surface is seen. Now these are the primary effects of negative pressure wound therapy. Then if you see the contraindications of negative pressure wound therapy or vacuum assisted closure, these are important. Here, malignancy. If there is malignancy in the wound, then we would not do this negative pressure wound therapy. Or if there is any untreated osteomyelitis or non-enteric or undrained fistula, if there is non-enteric or undrained fistula, or if there is necrotic tissue with eschar, in such cases we would not do the negative pressure wound therapy, right? So this is about the important points about pressure sore. One thing which I forgot to explain is in the stages there is some more depth which we can learn. So stage 1 is non-blanchable erythema and early superficial erythema. So in this there is only erythema. There is no breach in the epidermis. The epidermis is completely intact. That is one thing, that is non-blanchable erythema. Then we have, after this, the second right. Then if you see the second stage, which is late superficial ulcer. In late superficial ulcer, there is loss of epidermis with dermis. So here there is only loss of epidermis with dermis, but partial thickness loss, not complete thickness. Here there is partial thickness loss of dermis and epidermis is seen. Then we call it as late superficial ulcer. Not complete dermis, only the part of dermis is lost. Then in early deep ulcer, there is loss of epidermis plus dermis along with the subcutaneous tissue, right? So that is early deep ulcer. In late deep ulcer, along with the subcutaneous tissue, even the muscle is lost and bone is exposed. So this is about the stages of pressure sore which should be remembered. Thank you for watching.